Hello, welcome to part 6 of my introduction to Dermoscopy YouTube videos on training for GPs and GP trainees. Um, my name is Dr. Kwesi Appiah. I'm a GPA with a senior role um, in dermatology in Hertfordshire and West Essex area. So part 6 of this series is going to be focused much more on where we had left off from the last session, and this is pattern analysis as part of local features and global features, and we are going to concentrate on pattern analysis on facial lesions. And this is quite different from other rest of part of the body because I have said in some of my videos in the first series, we went through to tell you that facial pigmented lesions on the face basically show a rather homogeneous pigmentation, which is regularly spaced by the hair follicles. That demonstrate what we term as pseudo network on the face. So in cases of irregular and dark pseudo network, you always need to think about a lentigo maligna as a differential diagnosis from a solar lentigo and derma nevus, usually on the mature type of nevus, which are what you find typically on the face of most adults. So this is what a solar lentigo will look like. This is what pseudo network will look like. You have these brown, light brown macule on the face, and you can see these areas in the of it, which you can see that paleness in the in within the dermoscopy of this lesion, and these pale dots that you see there are where you have the perifollicular ostia. Or ostia, in which you usually will have hair follicles, and this is what you see in a dermal nevus, which presents mainly of a kind of a globular pattern of kind of a global appearance, a globular pattern, and usually clinically they will look much more bulbous and raised on the surface of the patient. So in facial lesions, the pseudo network is a homogeneous pigmentation interspaced by hair follicles. Atypical pseudo network, as seen in lentigo maligna, will have the dark brown to blue-gray structures superimposed in the typical pseudo network. And where these dark brown structures include an asymmetrical pigmented follicular openings, you get what we call rhomboid structures with annular granular structures and gray pseudo network, which make you suspicious of lentigo maligna melanoma. Okay, these structures eventually obliterate hair follicles, resulting in dark blotches in the structureless black pigmentation. So lentigo maligna, it's in its very early stages without epidermal varicose changes is very difficult to differentiate from solar lentigo. So identifying these dark structures such as the asymmetrical pigment follicular openings, the rhomboid structures around the these between the follicular openings suggest the beginning of lentigo maligna, which is really helpful to make a diagnosis of early lentigo maligna, which is a melanoma in situ because it's localized in the epidermis before it gradually develops into a melanoma, or lentigo maligna melanoma, I say, as in the absence of typical sharp demarcation where you find this with lentigo or lentigo-like borders. So this is a pseudo network. This is what you look like. This is what I'm trying to describe from that. This the pseudo network is this follicular opens, and when you see a dark brown area there, you're worried about kind of early lentigo, early lentigo changes. But these are what you get in pseudo network. So you can see all these brown areas. when it start evolving, and as it starts, there is a pagetoid spread of the melanosomes. You can see that it gets darker on these areas in what you call the rhomboid structures. So these dark areas are rhomboid structures. You can see it's so different from the kind of the typical network. So the atypical pseudo network with these dark areas on dermoscopy makes you worry that there might be some melanoma or lentigo malignant melanoma brewing on the face of this patient. This makes you that you need to refer this patient for 2-week wait for suspected lentigo malignant melanoma. Again, this dermoscopy helps the histologist for you to know where you're going to take the biopsy from. So sometimes you can have a very large solar lentigo on the face of the patient, and when it comes to seeing in a clinic, in a 2-week wait clinic, they want to confirm that these dark areas are kind of melanocytic changes suggestive of melanoma. Therefore, you can concentrate on the area and actually do a punch biopsy before the plastics or whoever is doing, or mostly MaxFAG, will arrange whether they need further treatment or white local excision or other various forms of treatment for melanomas in the face. So the other thing that we are going to look at in this part is we're going to look at the pattern analysis of pigmented lesions on acral surface. And the acral surfaces, I'm talking about the palms and the sole of the feet. So the global features of pigmented acral lesions display what we call parallel pattern of pigmentation. Anatomically, epidermal retiridges are arranged parallel. The crista profunda limitans or crista profunda intermedia, which are the surfaces. I'll show you the image of the cross-sectional surfaces of the palmar and the plantar surfaces are alternate parallel in the way they look. So the dermal eccrine ducts, which protrudes into the dermis or from the surface under the surface of the epidermis, are regularly connected with the crista profunda intermedia. So the crista profunda intermedia, where you have your ridges, as where you see the dermal eccrine ducts, which kind of where you sweat from, your sweat pores on the surface of your palms and your feet. This is where the eccrine ducts empty into on the surface. So this is what I'm trying to describe up there. You have the eccrine ducts on the ridges, and this is where they are found in the profundus, so eccrine ducts here. So this is where they are seen here on the ridges, the eccrine ducts on the ridges, but they kind of point towards into the dermal aspect of it. So you look at the patients in, this is a scanning electron microscopy here. You're looking at on the surface of the skin, and from looking from top, from bottom upwards, and this is where you see the eccrine ducts, which are protruding into the dermis. Okay, so this is turned upside down, and the eccrine ducts or sweat pores protruding into the dermis. So farus are the kind of the valleys there, and the ridges are the top there. So so you usually, when you have a fingerprint or thumbprint, what's displayed is the ridges. Okay, what's the ridges, the surface that is displayed on fingerprint, and the furrows are the indentations or the valleys in there, which will not show up on the fingerprint. So this is really good way to understand what happens on dermoscopy in the sole of the feet. So in acral lesions, the dermatopathological examination are cut perpendicularly to the skin markings. Okay, and when histologically the finding is very early acral lentigo melanoma in situ is scarcely diagnostic due to the very subtle pathological changes going on there. So you're looking at where the melanosomes are spreading from the melanocytes. Acronevi often would demonstrate an atypical melanocyte distribution, which is kind of indistinguishable from melanomas on histopathology alone. Hence, because of pagetoid spread, which is spreading sideways, it may occur due to areas of pressure, even in benign lesions. Okay, so differentiating can only be made on the basis on the distribution of the melanocytes within the lesion when the histologist the histopathologist is examining the lesion. So the first clue that you want to see is, melanocytic nevus tend to be confined to the crista profunda limitans, whereas melanoma cells are likely to be localized initially in the crista profunda intermedia and later spread more widely. So intermedia usually will be where you find the melanoma cells, whereas the nevus cells will be in the limitans. When we come back to the image at the next slide, I'll show you what we're talking about. And so if you can see the distribution of the melanocytic pigments in the furrows, it means that it is fine, because the furrows are where you find the profunda limitans, the limitans, whereas the ridges are the rogue ones, as where you find the intermedia parallelly to that. So hence the importance perpendicular cut histopathological specimen, which clearly illustrate that the relationship between the skin margin and the crista profunda is important for where the melanoma cells and the nevus cells are concentrated. So dermoscopy, by assessing this distribution of the melanocytes in relation to the crista profunda together with the dermoscopic assessment, then it is possible to differentiate with early melanoma features on the nevus if it's seen in the sole of the feet. So again, this is the diagram of what we're talking about. This is where the limitans is, again, and this is where the profundus is. Okay. Sorry, I'll go back again and show you what I meant. That I'm not meant to click that. So in the intermedia, is where you get the melanocytes and melanoma cells spreading here. So melanoma cells spread in the intermedia. Okay, in the intermedia, whereas nevus cells are in the limitans. Okay, limitans so correspond to the furrows. So limitans correspond to the furrows, limitans correspond to the furrows, and therefore intermedia here correspond to the ridges. So when you see melanocytic cells or melanoma cells, there will be more in the intermedia. Okay, intermedia, that's where the eccrine ducts are from. Okay, so the ridges along which the eccrine ducts protrudes from the surface of the skin, as is where melanoma cells in parallel arrangement will be found. This is really important to understand, that parallel cells will be in the intermedia, whereas the limitans are there. So this is what we're looking at. When you see the parallel furrows on the acromelanocytic lesions, you can get a parallel furrow pattern. You can also get parallel lattice pattern, or you can also get parallel fibrillar patterns. So these fibrillar patterns, lattice patterns, and furrow patterns, they are all areas where benign melanocytic cells will show itself on the acral surfaces. However, in the ridges, when you see any parallel pattern in the ridges, then you are looking at melanoma cells. Okay, any parallel patterns on the ridges are melanoma cells. So most acromelanocytic nevus will demonstrate parallel furrow patterns, lattice-like patterns, or fibrillar patterns with regular and concentric distribution of pigment, whereas with acromelanomas, they tend to show a parallel ridges pattern with irregular distribution of the colors and structures. This is very, very difficult to assimilate even for people with dermoscopy. I understand that, but with looking at more images and more practice of dermoscopic features of the palmar or plantar aspect, you'll be able to appreciate what we mean by these parallel furrow, lattice pattern, fibrillar pattern, or what a parallel ridge will look like where you're worried about a melanoma. So the basic dermoscopic pattern acromelanocytic lesions are some this way. So this is a parallel furrow. So these are the eccrine ducts, sweat pores on the sole of feet on the ridges, and the pigmentation will be on the furrows. Okay, the valleys on the furrows. So this parallel furrows is benign. When you see pigmentation crossing the ridges, they are not parallel but perpendicular to the ridges, and then also pigmentation on the furrows, it produces the lattice pattern. Occasionally you see pigmentation which are also not necessarily perpendicular but crossing or diagonally across the ridges. This is the fibrillar pattern. Again, they are not parallel to the ridges. If you see any pigmentation parallel to the ridges along the line where you do the thumbprint or eccrine sweat glands, these parallel ridges pattern is likelihood of this is a melanoma. Okay, so far as the parallel pattern is not parallel on the ridges, even if it's across it or parallel in this way in the lattice form, then you are rest assured. Whenever you see a parallel ridge pattern, you worry about a melanoma. So a couple of images for you to demonstrate what we are seeing in the schematic, the previous diagram is typical acromelanocytic nevus, which shows parallel furrow patterns. So you can see the furrows are parallel, the furrows are parallel. Okay, the furrows are all parallel. Okay, these ridges are all fine. They are not parallel ridges, but you can see the line in there. Okay, and there are 4 variants of this because of the way of pressure distribution on the surfaces of the palm and the sole of the feet. You can see the parallel patterns in different ways. So it's either a single line furrow, parallel furrow pattern, or a dotted line parallel furrow pattern. You can have a double line parallel furrow pattern, or you can get a double dotted line furrow parallel furrow pattern. Okay, so this is all parallel furrows by different variants in the dot pigmentation. This is what we're talking about. There's a single line is just on dermoscopy. You can see a single line, but you remember, look at that. Your ridges are fine. Your ridges are fine. They are not parallel. Again, you might see this. You might think this is a ridge, but this is actually the ridge, and the furrow has got a bit of a single dotted line. You can see the pigmentation is parallel. Another one is these are the ridges, and these are the furrows, which has got looks like a double pigment and double pigment, but the ridges are all fine. The ridges are all fine. So I mean, when I say ridges are fine, the ridges are not parallel. Because they are furrows, they are fine. So parallel furrows are fine. Again, the double dotted parallel furrows here. These are the furrows. These are all the furrows, and these are the ridges. There is no pigmentation on the ridges. You need to do these several times and see dermoscopic image several times to really grasp this. Okay, it's really important. So acromelanocytic lesions who have lattice pattern, mostly observed in the arches of the feet, and is composed of parallel furrow pattern and plus transverse lines on the crista. In fibular pattern, this tends to be on where you have the pressure loaded areas on the sole of the feet, or the sole or toes. And then, you can consist of kind of oblique melanin columns on the horny layer due to the body load on the sole of the feet. So as this is demonstrated, you have this lattice pattern here. So this is the ridges. This is the ridges, and these are the furrows. Okay, but there is also some cross perpendicular pigmentation across the ridges, but not parallel to the ridges. Okay, so but the furrows, the pigmentation is all parallel to the furrows. In the fibular pattern, this is how it looks like. Again, there is a parallel pattern across there, and again, it's because of where this sole of the feet is distributed because of pressure. Okay, so this will be in the arches, and this is over areas of the heel or the toe where there is pressure, which gives you the parallel fibular pattern. Parallel ridge pattern. Whenever you see, you can see that these are the furrows. The furrows are the light areas. The furrows are the light areas, but the pigment is abnormally distributed on the ridges. Okay, these are pigments. So on the ridges, on the ridges, on the ridges, on the ridges, and irregularly distributed in this dermoscopic image. This is an acromelanoma. Okay, and it's an area of paleness, some regression going on there in this lesion. You were an acromelanoma. Okay. All right. And the sensitivity for this approach in diagnosis is about 86%, and specificity for acromelanoma is about 99% for a parallel and ridge pattern diagnosis. So ridges are rogues, furrows are fine. As I said, with a fibula, because of the weight bearing, it's very difficult to appreciate the parallel nature of it. So there is a way of which you can use what we call oblique view dermoscopy, where you tilt the dermatoscope instead of looking at it parallel or at this angle, you tilt it in an oblique way to really appreciate the pattern. So in my own way, if I angle it in an oblique way, I'm able to appreciate the fibular nature of the parallel changes. So when the fibules or fibular pattern shows are short and just confined to the width of the ridges, you might not be able to be confident in saying that this lesion is benign. But when you use oblique dermoscopy, by doing it in an oblique way, you were able to do that. So this is how oblique dermoscopy does that. When you look at it sideways in its under dermoscopy, like how I was showing you, so that instead of doing it straight, looking obliquely, you're able to help you to appreciate that this is a parallel furrow where you're looking at, so because of where the pigment is on the furrows. So horizontal displacement of the horny layer by body weight makes melanin column slanting, observed from right above in this arrow, and results in fibular pattern. However, if the direction observation is changed, and what do you see? You see the parallel furrows. Okay. Fibular pattern. And then when you use oblique dermoscopy, this is image that you show here. Sometimes you use with video dermoscopy or kind of oblique pattern. That's what tells you that this is parallel furrow pattern that you're looking at. Okay, the result is dramatically, when you look at it, this image is taken from a video dermoscope, which shows parallel fibular patterns or parallel furrows. Good. So finally, as a sole of the feet, one thing you need to always try to differentiate from melanocytic lesion is a talon noir or black heel. and patients will often tell you that they've seen black spots in the sole of the feet. And if you look at the dermoscopic, the sharp demarcated area is a corneal hemorrhage. You can see the parallel areas, which will be in the furrows, but also the ridges also has a bit of pigmentation there. But then if you look at the mark of the well demarcated area as opposed to the previous melanoma image that I show you, you're able to appreciate that this looks like more of altered blood. Is reddish brown in there, and you can use a scalpel blade to just scrape the conified layer on the surface, and you can see all altered blood there. It might take a couple of weeks for it to disappear, but really this tells you that you are not dealing with a melanocytic lesion. This is blood. So beware of the talon noir, subcorneal hemorrhage. Patient will probably tell you there's no trauma, but dermoscopy will tell you there it is. Okay, so other pattern analysis that will help us for you to, in a second step, to differentiate between melanoma and benign melanocytic lesions will be the ABCD rules, Mendes rules, 7-point checklist, chaos and close, blink algorithms, TADA. All these are kind of demonstrated in some kind of some authors there in if you read the literature online in various websites. We're not going to go into that pattern analysis. So this video we demonstrated what the pattern looks on the face and the pattern looks on the palmar aspect of the and the plantar aspect of the hands or acral surfaces, for you to be able to distinguish between melanocytic nevus and the melanomas. Thank you, and then we'll be stopping the video here, and we'll get to part 7 in the next video.